The session will run from 1 o'clock to 3 o'clock with a short comfort break about approximately halfway through. And finally, please try to keep yourself muted if you can during the presentations. There will be space and time to have discussion and general question and answer, however, so please add any thoughts, comments or questions using the chat function in Zoom, and we can gather things there and come back to them later. Also, to let you know, we will circulate a summary report after the event, so you will have the information in written form too. And as always, we're always happy to be contacted for anything else. I just want to, first of all, I'll do a brief overview of the plan of the workshop. So yeah, this is the plan for this afternoon. We've broken it up into kind of multiple shorter sections, and we'll go through the findings of the study and share some of the other work that's ongoing at the moment within the group. Your feedback, or everyone's feedback, thoughts and discussion are really important for how we develop this area of research and practice. So we have scheduled time to discuss in smaller groups and gain your input, and we'll do our best to stick to time. So as I said, not any more of me talking, over to Professor Brittenden, who will talk through the problem of peripheral arterial disease.
Thank you very much, Chris. And just to say, it's been a pleasure for me to be a co-applicant on the grant and to work with the study team, and I'm really grateful for all of the patients who took part in the trial. So Chris asked me to just give an overview of peripheral arterial disease, which I'll do so. Next, please, Chris. So it's actually quite a wide spectrum of disease. If you look at the figures on the right-hand side there, these are the arteries above and below the groin. And you can have disease in the arteries without any symptoms, but as the arteries become more furred up, the symptoms become more prominent. So you go from mild claudication to moderate to severe, and then on to critical limb ischemia. Claudication being pain on walking and then relieved by rest, and critical limb ischemia is characterized by the presence of pain when patients are resting, which is particularly bad at night time when the blood pressure is low and the gravity is reduced by lying flat. And they also have tissue loss and gangrene. And the main causes are furring up the arteries or atherosclerosis, which is exacerbated by diabetes. And the less common causes, such as vasculitis or Berger's disease, which is associated with smoking in young men. Next slide, please. It's actually a very common condition. So the prevalence is 4 to 7% of patients aged over 55 who have symptomatic disease. Actually, the people who have asymptomatic disease is much higher than that. It's about 10%, and once you get older, up to 70 is much higher prevalence furthermore. In terms of the limb, the outlook to the limb, you can tell I'm a vascular surgeon, talk about limb viabilities and amputations, but it's considered to be relatively benign in that only 10% require intervention to prevent limb loss and 1% require amputation. But that's very much a surgeon's view of it and really underestimates the severe impact this condition has on patients' quality of life and their ability to carry out their normal activity, to work, and the functional capacity that is severely reduced. So the quality of life in patients with peripheral arterial disease is equivalent to those with class 3 to 4 heart failure. They're just as limited as patients who've got severe heart failure and can't walk to shortness of breath. In this case, they can't walk due to lack of blood supply to the calf muscles or the muscles in the leg, such that they have to stop and rest. So 50% reduced functional capacity compared to a healthy population. And associated with that, they have a 3 to 5 times increased mortality from cardiovascular causes. And that's because the furring of the artery I showed you in the first diagram doesn't just occur in the leg arteries, it also occurs in arteries throughout the body, including those supplying the heart. So it's a systemic disease. Next slide. And we've known about the association between peripheral arterial disease and all-cause mortality or reduced mortality, increased mortality rather, for a long time now. This is quite a well-reproduced graph dating back to a study in 2001. And you can see it shows survival over a period of 12 years for normal subjects, those who have peripheral arterial disease, which is mild, asymptomatic, those with more severe disease, and those with quite severe disease. And you can see a substantial reduction of 5 years survival in patients who have peripheral arterial disease. And this is mainly due to cardiovascular events, myocardial infarctions and strokes being the two most common. Next, please. Now, diagnosis of peripheral arterial disease is actually pretty easy. You get it from the history. This cramp-like pain in the muscles when you're walking, buttock-fine calf, relieved by rest. It can sometimes be confused with spinal claudication due to problems with the back, or venous claudication due to problems with the deep veins. But otherwise, it's a fairly characteristic history. Then on examination, you can see signs of reduced capillary turn. So you just have to press your big toe and see how quickly the blood comes back after you've blanched it, and also the presence of pulses. And then there's a really easy test that you can do called the ankle breaker pressure index. That's just like doing a blood pressure off your leg. So you put a blood pressure cuff around the lower leg. You use a Doppler probe rather than stethoscope, and you get a recording. You look at the ankle pressure compared to the breaker pressure, and that should be 1. Okay, that's what's normal. And if you exercise, it should go above 1. There are also automated devices now, which makes this process even more easier, so you don't need to be technically expert at it. Now you can see from the slide there that the lower the ABPI, so the red line is an ABPI of 0.4 to 0.85, the lower the survival at 5 years, and the blue one, the lowest one, dark blue, is those patients with an ABPI pressure of less than 0.4 ratio, and you can see a substantially reduced 5-year survival there. Just emphasizing how important it is to diagnose peripheral arterial disease in these patients. Next slide, thanks. So we have NICE guidelines. We also have SIGN guidelines as well. The NICE one's the most recent from 2012. And they divide the treatment of patients with PAD into 2 categories. And these are mainly patients with claudication, not those with critical limb ischemia, the rest pain, or tissue loss. First thing is to improve survival, and this is secondary prevention, not primary prevention. And this is through lifestyle changes, diet, weight management, and exercise, smoke cessation. That's really quite difficult to achieve, these ones. And then the drug therapy, the statins to reduce the cholesterol and also reduce the changes in the blood vessel wall. There is some evidence to suggest that statins improve walking distance, antiplatelets to reduce your risk of having sticky blood and clogged up vessels in the lower limbs or the heart, blood pressure control, and the diagnosis and management of diabetes, which a lot of the patients have and don't know that they have. For those who do have diabetes, the better you control the diabetes, the better you can improve the outcome of the leg, because amputation is much higher in the cohort of patients who have peripheral arterial disease and also diabetes. And then the other mainstay in treatment of NICE is this improved functional capacity and quality of life. You'll notice there's nothing there about improving pain, because there is no recognised treatment or methods of improving pain in this cohort of patients when they walk. So, and the recommendation from NICE is to, based on all of the randomised controlled trials, is to undertake supervised exercise therapy for patients 2 hours per week for a 3-month period. That somewhat underestimates the compliance rate that's achieved with exercise therapy, and it doesn't really address what happens after your 3-month period. Do the patients then go on to alter their lifestyle, increase their daily activity? It is unclear, but that is what's recommended through NICE. If you don't respond to exercise therapy, then you could be prescribed natriuretic, which is a vasodilator, which also causes flushing and redness and diarrhea. So it's not particularly well tolerated, or you could consider intervention such as endovascular treatment, angioplasty or stenting, but that's not readily available in the NHS at the moment, given the situation we find ourselves in post-pandemic. Moving on to the next slide. Yes. So despite the guidelines and the importance of the condition, this is a really underdiagnosed and unrecognised condition. Unfortunately, it's in the top 5 of the most underdiagnosed diseases. There's a lack of awareness in the population, and in particular, people over than 50 should pay special attention to the aches and pains in the legs and not attribute it to aging and natural phenomenon. It could be peripheral arterial disease, and they really should pay attention to it. It's also underdiagnosed globally. So this is recent data from America, which is applicable to the UK as well. So 20 million people are estimated to have peripheral arterial disease in America, but only actually 8.5 million are diagnosed. So 50% underdiagnosed, are not diagnosed. And Hirsch recently, in a PAD Awareness Day in America, said that women in particular suffer an immense burden from peripheral arterial disease, yet critical current data demonstrate that most women still remain unaware of their risks, so they are disproportionately affected by being underdiagnosed. Next slide, thank you. They're also undertreated when they are diagnosed, which is really unfortunate, because the rate of deaths and the healthcare costs associated with patients with peripheral arterial disease are at least comparable to those of heart disease and stroke. If only I could say that the amenities and the facilities were the same for patients with PAD as heart disease and stroke, but unfortunately they're not. Furthermore, most adults in the US who have peripheral arterial disease do not receive secondary prevention that could reduce the risk of MI, stroke and death. Loads of studies show that there's a link between cardiovascular endpoints and poor risk management of these patients. We've done a number of surveys in the UK through the Vascular Society, and we have shown a steady improvement in risk factor management in patients with peripheral arterial disease, which is very reassuring for our patients. However, what remains a source of considerable concern is the fact that only a third of UK vascular surgeons have access to a supervised exercise program. Many of the vascular surgeons do not have access to specialist nurse who can deal with change in behaviour or behaviour management or address the widespread aspects that need to be considered for patients who have peripheral arterial disease. So you can see that there's an unmet need, it's an underdiagnosed but very important condition, and there was a real need to take for this PrEPAID study, which I'm now going to hand over to Chris to tell you more about.
Thank you very much. Thank you, Julie. So yes, as Professor Brittenden mentioned, I am going to now just provide a brief summary of the PrEPAID trial itself. So, as Professor Brittenden has succinctly summarised the problem of peripheral arterial disease, we can clearly see that there is a need to enhance the current care for people with this condition. We were specifically interested in the relationship between peripheral arterial disease and physical activity, as we felt that this was very important, both for quality of life and hopefully preventing further cardiovascular complications. Before we develop or test any interventions, it's always really important that we need to understand a bit more about the specific nature of the problem. And therefore, we conducted a review of the barriers and enablers for physical activity as reported by people with PAD and IC. What we found was that the barriers were identified mainly as pain, knowledge and understanding, and a lack of motivation to be active. And enablers for physical activity were things like support systems, cognitive strategies, positive beliefs, and availability of exercise programs. So using this information, we started to think about what might interventions look like that would help increase physical activity for people with PAD and IC. So this diagram hopefully outlines our reasoning, and I will talk you through it. So the key themes from our previous studies were limited understanding of the disease, as you can see here, and the pain, which is a barrier to exercise or physical activity. So the limited understanding was associated with this uncertainty about the importance of exercise and how best to exercise, and there were no established interventions or pain management strategies for people with IC. And what we felt was that this leads to this decrease in self-efficacy or confidence in an individual, and that then leads to a limited engagement with exercise or physical activity, and thus has knock-on effects for risk factor modification, the risk of further cardiovascular complications, and ultimately a decrease in quality of life. What we wondered was if we could develop an intervention or interventions to address these barriers and make use of the enablers that we had identified. And this is where the education and pain management come in. It's highlighted in green here. So the theory was that a patient-centered group education could perhaps use the enablers of these support systems, these cognitive strategies, positive beliefs, while also addressing this barrier of knowledge and understanding. And then at the same time, the pain management might address the barrier of pain. And so these two things together would hopefully have an effect on self-efficacy, improve that confidence for individuals to engage with exercise or physical activity, and thus avoid the break this downward spiral and enhance self-efficacy and ultimately enhance quality of life. So what might these interventions look like? Well, we have been testing some similar things before. So in a proof of concept study, we had already demonstrated that TENS increases pain-free walking and maximum walking distance on a treadmill. And a study led by one of our other co-applicants, Professor Chu, developed the patient-centered group education, which was called CEDRIC here, and found that improved short-term physical activity. So it was upon this work that we developed the PrEPAID trial, which is what we're going to be talking about today. And it aimed to test these interventions together and individually. So the aims of the PrEPAID trial were as stated here on the slide. So as a feasibility trial, the aim was not to determine if these interventions work, but to find out if it would be feasible to run a larger trial to test these interventions and explore if the interventions were acceptable for people with the condition. So specifically, the objectives were to kind of estimate recruitment rates and retention of participants in the trial and explore participant experience of the intervention and trial procedures, while also getting an indication about the efficacy of the interventions. So the trial design is as stated here. So it was a 2x2 factorial design where we randomized 80 people with peripheral arterial disease and intermittent claudication and compared TENS versus placebo TENS with and without patient education. You can kind of, hopefully it might be a bit small, but you can see there's 4 groups identified here. So participants were required to be able to walk a consistent distance on a treadmill with less than 20% variation from week to week and not be awaiting surgical intervention. And we blinded participants to the type of TENS they received and also blinded the researcher who was measuring the primary outcomes to which group each participant was in. So high frequency, in terms of the interventions, the TENS consisted of a device that participants could use at home for 6 weeks, as indicated on the slide here. And the placebo TENS was achieved by using the same device, but locked to an ineffective stimulation parameter. And participants were asked to use the device as appropriate for them and their lifestyle, switching it on only when needed. The education intervention was a 1 hour, one-off 3-hour structured patient education, and it followed the CEDRIC curriculum, focusing on knowledge and perceptions about the disease, risk factor modification, and self-management of walking behaviour. So this one-off session was followed by 2 weekly phone calls, so a phone call every 2 weeks, where individual goals were reviewed and revised. So in terms of recruitment and eligibility, the participants were identified via Claudication clinic lists and approached either by their surgeon or by letter. If they agreed to participate, they were invited to attend 2 visits, 1 week apart, to complete their baseline measures and final eligibility assessment, which included that variation in treadmill walking distance. So we measured their walking distance on the first visit and the second visit, and if there was less than 20% difference between the absolute claudication distance or maximal walking distance on those occasions, then they were eligible to participate in the study. So if the participant met the eligibility criteria, they were automatically randomized to one of the 4 groups as shown on the screen here. They were then invited to attend an intervention visit. So if they were randomized to one of the education groups, they generally would have to wait until there was enough other participants randomized to form a group. Or if they were randomized to just one of the TENS interventions, then they could arrange that visit at their earliest convenience. There was an end of intervention visit occurred at the end of the 6 weeks for all of the interventions, and then we also completed a follow-up assessment visit, which was 1.5 months after the end of the intervention visit, and 3 months after they had received the intervention. And due to COVID, rather than focus groups, we ended up completing the kind of final follow-up as a semi-structured interview over the phone. This is the list of outcomes that were, excuse me, yeah, these are a list of outcomes that were included, that were recorded. And these efficacy outcomes that are highlighted in yellow were measured at every time point, so at baseline, at end of intervention, and at the follow-up. Okay. So that is a very brief summary of the PrEPAID trial, trying to kind of highlight some of the key important aspects so that the rest of the presentation makes sense. What I'm going to do now is move on to a brief summary of the participant experience of the intervention. Excuse me. There we are. I'm just sorry. So yeah. So what I've done here is I'd hoped to have some real life participants in the room with us today who could have talked about their experience. But in lieu of that, what I've done is I've gathered some of the comments that we received from the participants at the end of the study and the interviews, and I'll present them in a kind of case study approach using pseudonyms, so to give you a sense of the experience of the study and of the interventions. So this first participant, who we're calling Fred, what they said was that no, none really, no. I'm still quite independent. It's not getting any worse, that's for sure. But they weren't overly impressed at the impact of intervention for them. Liz, when asked about the effect of, and just to give you the context, all of these participants had experienced both the TENS and the education intervention. So they were one of the combined groups. So she was saying it definitely had a positive effect on the condition of my leg, no question about that. And you can read the rest for yourself, hopefully. So there was a perception that this had a good effect on their function. And as you can see from the second quote, that it actually perhaps participating in the study had impacted on some of the clinical decisions. For Brian, it wasn't so much of an effect in his perception, so he didn't find any great benefits, didn't make it any better, didn't make them walk any further. But yeah, they kind of forgot about having intervention. For Andrew, the TENS, he had a problem kind of fitting the TENS and using the TENS, so he struggled to kind of set the device properly. And I think because of that, he felt that it hadn't made any difference. As you can see, he kind of had that reflection of, well, it was perhaps me rather than the device. If he'd managed to get it set properly, it might have had more of an impact. For Shona, this is a person who'd had experience of TENS before for back pain, and she felt she had a really good benefit walking a lot longer. And would recommend it for anyone with the condition. And for Shug, well, he felt that it helped him on short distances, but not really for long distances. So he still got the pain again, which is interesting. I suppose to me that talks to perhaps the expectations that were set for these people in using the device. It's not going to be something that's going to take away the pain completely. And for Stephen, a bit skeptical for using TENS, but he has seen how much improved his walking has been, and distance has almost doubled since he's attended for the intervention. And for that, you can see he talks about it in terms of improving his mental health as well, due to that increase in walking performance. And Ray felt the TENS machine did help as well. Maybe you could walk maybe 300-400 yards compared to 100 yards before. So again, a good improvement, but interesting there. I said when the TENS machine got taken off, it was back to as bad as ever. So again, there's that. That might be important, I suppose, when we come to look at some of the results later on. So in general summary for TENS, that there was a perceived benefit, but some find it difficult to use, and they noted both the physiological and psychological impact. So then these quotes were more focused on the education. Fred felt that slightly better with the education, insight of what's going on, how to combat it, and this change of kind of approach to the disease, trying to keep moving, trying to keep walking. Liz felt that the education was successful, and what was something to do with the combination of both the education and the TENS together. Still have occasional pain, but it doesn't come on as nearly as quickly as before. And you had quite a lot to say there. Hopefully I'll give you a minute just to read through this. But I would generally you can see this change in perception, change in way of thinking about the condition, and about understanding what you need to do about it, and possibly improving those kind of self-efficacy beliefs. Now they know about it. And yeah, it's interesting that quote there at the bottom, talking a bit about fear or kind of negative feelings about the condition, and those have changed with that increase in knowledge. Fiona, feeling it's helped her because she now knows you need to walk more, so it's changed those beliefs about what they can do, what she is able to do to help control the condition. And enjoyed the kind of being able to share experiences and share the condition with other people within the group. And again, mentioning this idea of fear of the pain in the legs, it says, but now that she knows a bit more about it, or has perhaps kind of had some of her worries addressed, more able to engage with the walking and walking into the pain. And again, Stephen, a generally positive experience of the education, learning and listening to others' experiences was really important for him. And Ray, noting that he's changed behaviour due to the education session, so putting a bit more effort into the walking, and not using the car perhaps so much. So in summary, in terms of the education, that the overall experience was very positive, and different noting changes in attitudes and beliefs and perceptions of their disease and experience. Okay, that was a very whistle-stop tour. I hope you managed to pick up some of those quotes there, and we will obviously be exploring these in more detail in a minute as we go on through the session today. So now it's my pleasure to hand over to Andy Elder. Andrew, I think you're here, is that right?
Yep. Hi, Chris.
Hi, Andy. How are you? So I will, if you just let me know how you'd like me to click through your slides, and over to you to go through the results.
Okay, thanks, Chris. Hello, everyone. I'm Andrew Elders. I'm a statistician at Glasgow Caledonian University, and I'm part of the PrEPAID trial team, and I've been involved in analysing some of the quantitative trial data. So I'm just going to spend the next 10 minutes or so just summarising what data or some of the data that we collected. Go to the next, please. So this is the top half of our consort flow diagram, and we'll just go through it. There's over 1,000 people assessed for eligibility, most of which were ineligible according to our inclusion and exclusion criteria. So 267 were approached, and about 50% of those declined. That's a very normal amount of non-participation for various reasons, and that's kind of typically what we see in trials. Obviously, some were missed as well, and we picked up further ineligibility at that time. So there were 95 that really participated in the study, and we collected data on those 95, but 38 have failed the treadmill criteria, and So ultimately, 56 were randomized into the study. This wasn't quite the 80, I think it was, which was the target sample size. But you can see the reasons all listed at the various stages why that's why people dropped out before the randomization point. So once the 56 were randomized, next slide. So this is we call a factorial design. So there was just the two interventions. A quarter got both. A quarter got placebo, and a quarter got TENS only, and the other quarter got placebo, TENS, and the education. And there was it was an even split. So there were 14 allocated to each arm, and we got a complete data at baseline on everybody. But as you can see, as it would go through the different time points, so follow-up 1 at 6 weeks, we'll have 1 or 2 in each group were lost to follow-up. That's at 6 weeks. We had about I think it was just 1 in each group for whom we didn't have questionnaire return. So that's like over 90% completion, which is very good retention compared with lots of similar trials. And after 3 months, it was between 10 and 13 in each. So again, it was between 80 and 90% retention at 3 months. So that's generally considered to be quite good retention there. Next, please. So these are the feasibility outcomes, and these are kind of outcome measures that we're particularly interested in a feasibility study. There's quite a lot of data that we collected around participation of different parts of the study, and so this is not the whole set of that data. So the top part of that is the adherence, and this kind of actually fits in with what Chris was just saying, that although people were happy using the TENS machine, in fact they found it difficult to use at some point. So the adherence rates are not that great. One thing you notice in each of the groups is the objective diary adherence, the patient reported one, is much higher than the strict objective record from the machine. And you can see that we don't have data on everybody as well, as it's about 2/3 who actually responded with the TENS diary. But yeah, so overall, there's definitely room for improvement, I would say, with adherence. There was the acceptability of the TENS unit was quite high for a number of issues, as you can see. The lowest one being comfortable to wear. Only about half of those in the TENS group found it comfortable. But other in terms of ease of use, it was generally scoring quite highly. And you can see that right across the different randomized groups. There were very few adverse events. There was only 3 out of the whole 56 participants that we've looked at here. So in each case, it was itching. Okay, next, Chris. So the remaining slides are just going to give an overview of the different outcome measures that we collected. About half of these measures were that we'll come on to in a few minutes were patient-reported ones. But the first set of measures to do with the physical exercise data that we collected from the participants. One thing to think about is that we didn't design the study to measure differences between the groups. That's what a full study was doing. We're mainly interested in seeing, is it feasible to do a main study? Can we collect all this data? But as you'll see, we were able to collect data on most of the participants for each of these outcomes. So that in itself is promising. The numbers up here are averages. These are the mean values for the 4 groups over the 3 months. You can see it summarized in the graphic. So walking distance, pain-free walking distance, does what we're going to see here is for most of these, we don't see much difference between the groups for any of the measures. But we're not designing the study to look at that. But we're able to see that there's a bit of an increase in most of the group, in all the groups, I think, over time. So that's a benefit in the trends there. Next, Chris. With maximal walking distance, it's a bit flatter. It's averaging about 300 meters or so, and that doesn't seem to change. Be careful how you look at this. The education only group seems to be a lot higher here, but they started off higher. So in terms of you can't really read anything into that in terms of effectiveness. Next, please. Number of steps. Again, it's fairly similar between the groups, and does decrease in a couple of groups, which I don't really understand. Anyway, next, please. Yeah, this is a number of upright events. This is again, we're able to collect the data on. It's kind of averages at the start of a baseline between about 40 to 45. Maybe a slightly greater spread as it goes over time, but again, it's probably not huge differences, but maybe over time. Next, please. Events, like nearly every group has the same trajectory here. It's a decrease from about 300 to somewhere between 200 and 300. Chris, can I ask a question at this point?
Sure, yeah.
Is a decrease in walking events, is that a positive outcome?
It could be. What it might indicate is that, so obviously walking events are how many times, and this is recorded by the active PAL, that it records a certain, it records this person being walking. And obviously if someone's walking longer, for longer distances, they may stop less, and thus the number of walking events may decrease. Julia, do you want to come in there?
No, I was going to say exactly what you said, Chris, that they could be walking for longer. Rather than, so it's difficult to put this into context. But I guess the steps, and this, could you go back to the steps one, because that might help. So they're not really walking longer.
Mm-hmm. Yeah, so that may not necessarily be an indication of effectiveness. Okay, next, please. Yeah, so in a way, this kind of helps us to maybe understand, because this takes into account the distance and the number of events at the same time. But it's generally quite flat across the board. Next, please. So this is a physical component score. This the SF36 is a generic quality of life measure. Yeah, and in the see, particularly in the ones with the education, it definitely seems to decrease somewhat in the first 6 weeks, but that benefit is not sustained beyond that. The average for the population is 50 for this measure, so everyone is in a group that on average is considerably below the average, which I'm sure is what we would expect. But yeah, so it's actually this decrease is not beneficial. Next, please. And again, the mental component scores, does seem to go down a little bit as well. So these, but these scores, if they go down, that's not a good thing. But again, these scores are all very low. But crucially, there's all very similar between each group and doesn't really change much over time. Next. Intermittent claudication questionnaire. Chris, can I ask you to come back in? I've forgotten what this is.
It's just a disease-specific quality of life measure. So it asks specific kind of questions related to quality of life, yeah, for the population.
Yeah. So is a higher score better?
Yes.
Yeah. So this is where you can see an improvement in the first 6 weeks. In each of the groups, but not thereafter. Next, please. And again, we see like it's like increase here in the depression scale, and that kind of fits in with the mental component scores as well, not being great. Next, please. Our pain measure is, yeah, it doesn't seem to have any effects over time on there. Again, these differences are really quite small between the groups. Next, and that's very similar to the last. Next. This is interesting because this is a decrease in the first 6 weeks in terms of pain intensity. This is measuring. This must be measuring something that's different then to the pain, the McGill pain questionnaire. But this focuses specifically on intensity of pain, obviously, and seems to be in each of the groups there's an improvement in the first 6 weeks. Next. There's no real changes at all in the brief illness perception questionnaire. And I think that's the last measure, isn't it?
That's right, yeah.
Yeah. So to summarize, we're able to identify a lot of our participants, but we didn't quite recruit to target because there were lots of reasons why people didn't participate. But we were able to successfully randomize those that did participate, and there was good retention within the study. there is a quite good acceptability of the interventions. There is no significant safety issue. There is definitely issues with adherence. In terms of collecting data, we can see that we've collected a lot of data and a lot of outcome measures. So that's a real positive from this. And there may be some benefits that potentially are worth investigating in a full trial. Particularly, there are benefits that seem to maybe exist within the shorter term, but may not necessarily be extended over the longer term. So that's a kind of summary of some of the data that's been collected. There was, as always with these studies, a huge amount of quantitative data, and there's a lot more that we could have shared with you today, but that's just a bit of a taster of what we have collected and what we have found. Okay, thank you.
Thank you very much, Andrew. That's really useful. Yeah, I think that obviously, if you remember going back to, as you just mentioned there, the important thing was that how feasible is this, is the design of a study like this? Can we recruit people? Can we retain people? And what's their experience of participating in the study and receiving interventions? So I think on those questions, as you mentioned, the kind of quality of data, the completion rate of outcome measures is very good. And the fact that participants came back and returned for the follow-up visits is very good. In terms of those effects that you're seeing, it does seem to be some sort of effect in the first 6 weeks. And it was interesting, I think quite a lot of those graphs, the two kind of education groups seem to move together. So almost that there seemed an impact of the education unique to the TENS. But to look into too much more detail is hard with the numbers and the power in the study. Great, thank you very much. So I'm just conscious of time, so we are kind of running a little bit behind, but I'm going to share briefly the qualitative findings that we have from the interviews. So that's looking at the acceptability in some more detail, and then we're going to go into breakout room discussions where the hope is we can discuss these types of things in a bit more detail and get all of your perspectives on this. So in terms of the qualitative findings, just to remind you, so we had this a follow-up visit, which was 1.5 months at the end after we had the follow-up, which was 3 months post-intervention, and then we had this final kind of follow-up, which was an invitation to complete a semi-structured interview over the phone. And so the data I'm going to present is from these interviews. So we invited all participants who experienced both interventions to attend for one of these semi-structured interviews, and 9 participants volunteered and were interviewed via phone. The topic guide for these interviews were focused on the acceptability of the study and of the interventions, and we used a framework analysis using the theoretical framework of acceptability to analyse the transcripts. Just briefly to demonstrate what this theoretical framework is, this is what it looks like. So what these researchers developed this framework of acceptability for health-related interventions, and that for something to be acceptable or unacceptable, it could be categorized in some of these aspects. So I'm going to present the results themed under these aspects of acceptability. So some will be related to the study procedure, as in the trial, how we ran the trial, and others will be about the intervention specifically. So to begin with, talking about the study procedure, under the theme of perceived effectiveness, some of the participants talked about the travel. So they said, well, no, the travel's fine because you can go by bus, practically at a bus stop, so it was easy to get there. it was quite a lot of other people felt it was awkward to get to, but because the hospital was putting on a taxi, so there was no problem. So it seemed like in terms of travelling into the clinical research facility, wasn't too much of in terms of the burden of attending for the trial, it wasn't too much. In terms of perceived effectiveness of the study procedure, that someone talked about the fact that they weren't sure. That I think they felt that they got the placebo TENS, or we were using TENS as a placebo to compare against education. So they felt that, well, rather than using a placebo, they wished that you would just get a real TENS machine, and that would it was less acceptable to them to be randomized into a placebo group, or what they felt was a placebo group. For the TENS, there was some data from the interviews that was themed under the self-efficacy. So self-efficacy talks about the participants feeling that they can complete the intervention, that they have the skills and able to use the intervention as intended. So a couple of people talking about the TENS, saying the usability was quite restricted. So on the length of the cable, the buttons on the TENS machine were sticking out. So if you knocked it, you either put the electricity up, or the pulses got higher, or you knocked the machine off altogether. And someone else saying he found it extremely annoying. I think people get fed up trying to fit it. So that speaks to perhaps, that ability to use that TENS machine, or how we train people to use the TENS machine might well make it less acceptable as an intervention. In terms of burden of TENS, some people were saying, well, no, it was fine, just put it on in the morning and switch it on when they needed, so they didn't have a problem with the burden of using the device during the day. But other people felt this bulkiness of it, and having the stupid thing in the pocket, feeling it was a bit obvious to others. Felt like they looked a bit like a robot walking around with a TENS machine on. So that increased burden of wearing the device, made it less acceptable, and therefore what they felt. And then in terms of perceived effectiveness, or how effective they thought the device was and how that related to acceptability, someone at the top, as you can see, saying, well, they stopped using it because it didn't feel as if it was doing anything. So because it didn't feel they were getting a benefit, they didn't feel it was an acceptable intervention, and stopped using it. And this other person, was saying that they again felt it was a good thing, didn't know about it, but they got one after the trial. They went and bought their own one because they felt it works more. So obviously an acceptable intervention. And then, someone else saying don't think it did them any good, so they probably wouldn't use it. In terms of effective attitude, and this just really relates to kind of how the intervention makes people feel, and therefore how acceptable it is. As you can see, it's a bit of a long quote. I won't read it out altogether, but it's this person felt it was brilliant and recommended it to their friends, and other friends have started using it as well. So obviously that kind of positive feeling about the intervention relating to feeling it's quite an acceptable intervention. And then the aspect of opportunity cost. So this is, what do you have to give up to be able to engage with the intervention? There were some people felt that a wireless one would probably be a lot better. So they felt that, and they wouldn't wear the TENS with a summer dress or anything like that. But then someone else said, well, the wires were just fine. If people are complaining about the wires, then obviously their pain's not bad enough. So they kind of have this feeling of, well, if your condition's bad enough, you're generally kind of swallow a bit of inconvenience in relation to the intervention. And then on to the education in relation to burden for the education. Someone felt it might be streamlined a bit more, and the other person said, well, that one day was fine there if they felt they were only there for an hour and a half, and they got everything they need. So kind of mixed feelings in relation to how often to attend for the education session. In terms of effectiveness, there's an aspect here of people saying, felt the exercise was helping, so wasn't, concerned about using TENS, so didn't bother engaging with TENS because they had such a benefit from the education. I would recommend it for other people because it was so effective for them. And in terms of how it made them feel, So this person saying they didn't get great benefit from TENS, but the program does make you think more what you're doing and what you're not doing, and a wee bit more movement into your life. So they had that general positive feeling towards education as an intervention. And someone said that education was wonderful. So fairly acceptable. So in terms of summary, this is just an initial analysis of these qualitative findings, but the study procedures were acceptable. The burden of travel was kind of ameliorated by providing taxis paid for through the study budget. The TENS was less acceptable if not perceived to be effective, if you either thought it was placebo or perhaps the experience of TENS was not great. And there was a burden with the size and the nature of the machine, specifically the wires and the length of the wires were a problem. Education was very well received due to the kind of how effective they felt it was, they felt, and how it made them feel. So they felt listened to and they felt able to share their experience. But it could be streamlined or with more regular meetings rather than a longer one-off session. Okay. So that brings us to our first breakout room discussion, where hopefully we're looking to get your thoughts and on these. On what we've presented so far. So we've pulled together a list of questions we would like you to think about, and we're going to go into breakout rooms for 10 minutes to talk through these questions. So we want you to think about the study, about what we presented so far. What are your initial thoughts about what we presented? What do you think are important take-home messages from the study? What have you kind of taken from what we presented so far? And then if the plan is that we're going to move on to the next study, a pilot trial, and hopefully develop it into a larger study if it all goes well. So what for you would be the 3 or more key changes to the study procedure or the interventions, how we deliver the interventions you think we should make? What changes should we make if we're doing this again? Okay. So Karen, are we ready to go with the breakout rooms?
Yep, so I'll open up the breakout rooms. I'll still be in the main room, so if anybody's got any issues, I'll bounce back. I can put you back into a breakout room. So I'll start them now, so it should automatically just add you to the room. But yeah, any problems, you'll just pop back to the main one anyway.
Thanks, Karen. Thank you, Julie. That'd be
Well,
great.
thank you very much to our group and for all the interactions. First of all, they didn't like the treadmill. They didn't think it was a reasonable outcome. It wasn't goal setting. It wasn't relevant to the patients. And they felt things like steps would be a better outcome, especially if you were loading them up and monitoring them and encouraging people to deliver more in terms of the steps. I'm afraid to say we weren't sure whether 10 should be taken forward in another study. I think the adherence bit and the design, unless you can come up with something different, perhaps look into how it might work and see if there's anything else in the market that could be, using the same sort of mechanism. But they weren't sure that we should be taken forward. There was quite a bit of comment about pain, how you measure it and when you measure it. I mean, I think that reflected, I know you did quite a few surveys there, but there was a question about whether the pain's been measured during the exercise or when it's most severe, as some of our patients have said, which is after you've stopped exercising and the blood's going back into the limb, which was quite interesting. So thanks for that. I think that was really important. And everybody seemed to be pretty keen on the education component and valued that. So that's all from our group.
Thank you very much. So I was just frantically writing some of that down. That sounds really interesting discussion. Great. Any of the other groups to give a summary of what they discussed?
Yeah, I'm happy to feedback from our group. I think it's interesting that Julie's group were talking about whether TENS would be suitable for taking forward. I think that definitely came up in ours, that perhaps it was only like 50% of people that was maybe, it did help some people, but it wasn't like everybody. And we had someone in our group who was talking about using virtual reality as a pain relief mechanism for use with PAD, and that gave them pain relief to go out and walk. And so maybe we weren't dismissing pain relief as a component, but maybe discussing other options. And one of the other things we're talking about, when people get diagnosed and when they Google things, there's a lot of negative information out there, and so being able to find good information on what to do is useful.
Excellent, thank you.
I can feedback from my group if you like.
Thanks, Gary. Yeah.
I'll just pick up on a couple of points. I think this has been mentioned already. It seemed like the patient education component was valued, and a sense that can have numerous benefits, like increasing the appreciation of what the condition is, maybe increasing appreciation of how walking can help. An idea, perhaps, if the intervention could be enhanced, maybe offering it over more than a single session, perhaps gives the opportunity for people to go away, think about it, process, and come back, and then clearly that impacts on costs and capacity to deliver that, but that's something that could be considered going forward. And just in the feasibility, it was kind of highlighted that the follow-up rates were good. So once we got people in, we tended to get the data back and people followed up. So from that aspect, it seems that the trial was feasible.
Excellent, thank you very much. That's some really nice and really useful feedback. Any other comments then at this point at all? Okay, brilliant. Well, thank you all for sharing your thoughts in those discussions. That's really useful to us, obviously, as a study team, as we're taking this forward, and we'll be able to include those discussions and those thoughts within our plans, really. So that just brings me, I'm just going to go back across onto the slides to show you where we are. So yeah, that we just had some, thank you very much for the feedback from the breakout rooms. What we're next on to is just a short break. So I would just propose that we just take a 5-minute break at this point to let everyone stand up, walk away from the screen for a minute, and then we'll come back for the next bit of the session. Okay, so if that's 17 past at the moment on my clock, will we start at 24 minutes past, or no, sorry, 23 minutes past? Is that all right? Everybody? Yeah. Okay. See you back then. Thanks. Okay. Hopefully I can see some people back and ready to go again. I'll just start sharing the slides again. Great. So now we are moving on to the next part of the session. So as you can see, we're down to this part here where we're going to hear from some of the other members of the research team at the moment, and it's about the other work that's going on within the group. Then following that, we'll have some discussion about that, and then bring everything to a close. Okay, so I will hand over now to, first of all, is Sean Paul, who is going to be talking about his current study, which is titled Motivating Physical Activity with Behavioural Intervention and Education, Electrical Stimulation Remotely in People with Intermittent Claudication. So, Sean, are you ready to go now?
Yep, I'm ready to go.
Perfect. Over to you. Thank you.
Hi, thanks for coming, everyone. I'm just going to give you a brief rundown of what I'm doing as part of the research group at Glasgow Caledonian, and part of my PhD. Next slide, please. So what we're proposing is that we have a non-pharmacological pain management or electrical stimulation, similar to what we've heard this morning, this afternoon, with telehealth delivered behavioural intervention, with the goal to improve physical activity, mainly just daily step count, so focusing on walking outcomes, which are important for people with peripheral arterial disease. So why are we proposing this? Well, we do have guideline advice to get people into supervised exercise programs, but they're not always available and people can't always attend them. There's a variety of reasons for this, normally accessibility and availability. It's also the complex challenge of circumstantial and behavioural health behaviours. So where you come from, what you have access to, what kind of habits you have, and how we manage them. And also, as it's been touched on before, limb pain and understanding of the condition of PAD are major barriers to getting involved in some kind of service. Chris, could you go to the next slide, please? Overall, behavioural interventions have been shown to be useful in other health populations as well as PAD in improving health-related outcomes. And also UK and NHS Greater Glasgow Clyde, Professor Bethenden, Professor too, have done a study showing that there is some positive response to behavioural intervention. However, there's an absence of this done via telehealth, and we now believe this is the perfect climate to trial it. We're more connected than ever, and while there might be alternatives, they may be subject to increased demand for funding, resources. There's also staff shortages, and there's a cost of living crisis on the horizon. What this might offer the NHS and their participants is that their service might become improved as a result of it. We might be able to also train staff. Now, at the moment, we're focusing on training physiotherapists. The only reason for this is that I happen to be a physiotherapist myself, but also it's part of the HCPC and the CSP framework of what consists of a physio and what's within the scope of their practice. So they're considered experts in physical activity and exercise, and they're also in a good position to do this within the NHS. However, that wouldn't exclude further allied health professionals or other professionals in the future. Next slide, please. Oh, I didn't know I'd done that. Why health behaviour change? Well, as we said again, there are alternatives, namely the one that's advised in guidelines is supervised exercise programmes are set. However, there's a bit of variation in the data showing that there does tend to be a significant dropout rate, and there's also a significant lack of patients who have access to it, and the added concerns of funding and resourcing that we spoke to before. So what we're also wondering is, considering rural populations mainly, but also these participants who can't make it to a supervised exercise programme, if they were offered something similar where they could do it in the comfort of their own home and have advice with a professional, would they uptake and adhere to it? Recently, a trial called the Mosaic trial was published and demonstrated that actually people do tend to adhere to it. My numbers are slightly off, but they didn't have as a significant dropout rate, and they did show that the 6-minute walk test can significantly improve in 3 months following a health behaviour change intervention. From memory, I think the improvement was maybe about 33 or 35 metres, which shows it falls a little bit short of the minimal clinical important difference, but still shows some change, and they did have a smaller sample. There's probably bigger implications here as well. By avoiding the need for an exercise facility or coach during exercise, home-based exercises are likely to be less costly, meaning that perhaps they can be rolled out to a wider population and available to more people. And they also have particular importance for those in rural areas. So when we consider how widespread Glasgow, Lanarkshire, Aberdeenshire, areas like this can be, this might have implications for our patients in Scotland. Next slide, please. So I had a look at, so we've considered the health behaviour part, but now considering the non-pharmacological pain management part, and we're considering using electrical stimulation for this. And when we had a look at the data, what we can see is there's lots of outcomes reported, but all the studies seem to be, or most studies seem to be done a little bit differently, which means we don't really have a consensus in how things work, but there are certainly some promise there. While we don't have a concrete answer on what to use and when, what's important, I think, is to be consistent and get our patients involved. So we go to the next slide. Just as it says at the bottom, the patient's an expert in his or her own experience, feelings, fears, hopes and desires. So while we might not have a concrete answer for what is the optimal electrical stimulation modality or usage, what we can do is get our patients involved and get them to give us feedback. The reason we consider electrical stimulation in addition to health behaviour change is that despite the fact we're addressing a lot of barriers with health behaviour change programmes and perhaps improving physical activity, there's still the barrier of pain, which we heard about earlier on. We don't want to just tell our patients to grin and bear it. We want to hopefully give them something which may have some use with it. But there are issues. So again, we said we need more studies for electrical stimulation with more people. Some of the protocols are quite unrealistic. But what we also found is that they should be packaged with education and physical activity advice. So now that's what we're intending and doing in a telehealth format. So yeah, let's give the patient a device and ask them how it goes. Next slide. Thanks very much for your time. That was as quick as I could get through that. Any questions?
Thank you very much, Sean. What I might do is I might hold the questions for now, if that's all right. And I'm going to hand over. We've got a Buka here, I think, as well, I believe, who's going to just have a really brief recap on his current work as well, if that's okay.
Yeah, hi everyone. Yeah, I'm going to be taking us through the project, which is part of the group, with the title Co-Creating Physical Activity Interventions for Intermittent Claudication with the tag CREATE study. Yeah, next slide. Yeah, just a bit of a background on the impact of physical activity, because we have gotten the background of peripheral arterial disease. Yeah, we all know that, it causes occlusion of the blood vessels, depriving muscles of the lower limbs of oxygen and nutrients, which leads to pain. So if you look at the graph, the flow chart here, you would see at the flip end, the impact of a PAD, ultimately results to reduce muscular strength and then altered working biomechanics and working performance, which summarily means reduced physical activity performance. However, engaging the patients in exercise training, as proposed by the NICE guideline, causes almost a reverse of the impact of a PAD. Yeah, next slide. So, however, the problem is that there is recorded a poor adherence to physical activity performance. Yeah, NICE guideline recommended supervised exercise. However, patients don't adhere to, these prescribed exercise intervention, and several interventions haven't been effective in improving physical activity in this population group. So thinking broadly, what could help? We talked about co-creation. So just, contextualizing co-creation is about involving creation of new knowledge by involving relevant stakeholders made up of the patients, clinicians, and academics in co-designing an intervention targeted at a particular goal. Yeah, so according to Greenhalgh et al., co-creation helps in developing tailored intervention. That's intervention that are sensitive to patient's environment, cultural influences, social influences, and several other factors that patient experience could reveal. So I could say that co-creation empowers end users, patients, to be involved in designing or developing interventions that would be tailored to their needs. The next slide. So the gap in literature is that, in as much as co-creation has been promising, of recent it has been proposed as a kind of design that could help, in ensuring adherence and uptake of a design intervention, since the end users were part of the design of the intervention. However, no study, to the best of our knowledge, has involved stakeholders in co-creating an intervention targeted at improving physical activity in patients with intermittent claudication, which is the problem we wish to address. Next. So the aim of the study is to co-create an intervention that will have both clinical effectiveness, social and resource effectiveness in facilitating uptake of a physical activity intervention in this population group. Next slide. So we are going to be using a PrODISIS framework as a kind of a guideline for the co-creation we propose. So the PrODISIS framework is just an acronym, to signify the problem, objective, design, end users, co-creators, evaluation, and scalability. So just, I wouldn't take much time in this, just the problem is the poor uptake of an adherence to the current physical activity interventions as recommended by the NICE guidelines. So our objective is to co-create an intervention involving these stakeholders. So we're going to be using participatory and appreciative action and reflection. So just to talk a bit about this kind of design. So this design doesn't only focus on the current problem, which is a poor performance of physical activity. It actually looks at the problem, and as well as looking at the strengths of what the patient could have identified as strengths, in encouraging them to participate in a supervised exercise program or daily physical activity performance. So looking at the strengths, it could be harnessed to develop something that could be tailored to augmenting whatsoever they have been doing. Yeah, next slide. So the co-creation is going to be in the form of workshops. So we are proposing an average of 8 workshops, which could change because co-creation is an iterative process. If the co-creators deem it fit to reduce the number of workshops or increase it, we could do that. So we are proposing that the first 4 series of the workshop would have the participants divided into groups. So the group 1 would be researchers and individuals with PhD and IC and their supporters. So and group 2 would be the researchers and the clinicians. The essence of this would be to create a safe space, because the first 4 series of the workshop would be dealing in trying to explore experiences of the patients, their carers, with PAD, and their experiences with the proposed intervention. So we would want to create a safe space so that they could comfortably express, their experiences with the interventions they have been using. Yeah. So, but the last 4 series of the workshop, we want to bring the 2 groups together for the purpose of designing the intervention. Next slide. So these are the potential workshop themes. So we are going to be exploring each of these topics. So we are currently proposing that the workshop will run once per month. That's if it's going to run for, if it's going to be 8 workshops, it's going to run for 8 months. So we're going to be exploring these topics. So from the 5th workshop, we'll be discussing an intervention and a potential intervention, which would have been created, designed, following recommendations from evidence, and then the experiences and recommendations from the stakeholders involved in the process. Yeah, so we hope that at the end of the workshop, there will be an intervention which could be subjected to a full trial. Yeah, next slide. So potentially, we are, expecting that the outcome of this project is going to bring a lasting solution to the poor uptake and poor adherence to physical activity performance within this population group. Yeah, thank you.
Thank you very much. That's really interesting. So, what we're going to do now is we'll possibly kind of hold some questions for Erica and Sean to the end, but we're going to go straight back into kind of breakout room discussions with a bit of a wider remit. So what I would like to focus on this time, we're going to spend another 10 minutes on this, is basically what do you think are the key areas that we should be focusing on in relation to increasing physical activity in people with PAD and IC? So we've talked about what we've done in the PrEPAID study. Obviously, you've heard from Sean, who's looking at telehealth, mixing kind of motivational interviewing interventions with pain relief using electrical stimulation to see if that will improve physical activity. And Abuka is going to be working with people with peripheral arterial disease and healthcare professionals to try and develop something from scratch using co-creation to see what would work. So these are the things we're doing. What are we missing, basically? What else could we be looking at? So Karen, are you able to set up the rooms again? I think we should be going back into the same rooms, and we'll spend 10 minutes talking through this and then bring it back together.
No problem. I'll set them up now, and then any problems again, you'll just pop back to the main room. So
thank you. Welcome back. Hope that was again another useful discussion with you all. I'll just make sure everyone's back in the room. So same as we did before, I was wondering if everyone would like to, or some people from the groups would mind kind of sharing a flavour of the discussion, what was kind of what was discussed, and any interesting themes or points.
Yeah, I can kick us off this time. So a few ideas in quite a short time, really. So the first one was around future research to help optimize the exercise prescription. So that could be looking into alternate modes of exercise. So if treadmills aren't available, what's the relative efficacy of different modes, the frequency of training, the intensity. There have been some studies on those topics, but I think it's fair to say that we don't really know the optimal exercise prescription, and future research would be helpful on that front. Kind of linking back to PrEPAID, some work to kind of enhance the acceptability of TENS as an intervention is a way of making that device kind of less intrusive, a bit more acceptable to wear, easy to use. Looking at telehealth, maybe looking at different systems. So the Florence text message system was mentioned as one potential vehicle for getting behavioural messages out there. How effective is that? What type of messages you need to do and what frequency? How does that link to other kind of support that people could be given? The idea of co-creation again, kind of getting different stakeholders' views and taking quite a broad view of stakeholders, so that we're getting commissioners' perspectives, we're getting kind of patients, healthcare professionals, everyone around the table to help build something that kind of works within the context of our healthcare system. More research around home-based programs. How can we optimize those? What are the necessary components? How do we get a larger proportion of patients engaging in physical activity, which can be for some people quite painful to do. So how do we get around that barrier of pain and get people engaged? A few ideas from our group, so thanks for the feedback.
Yeah, that's really interesting. Thanks, Gary. Thanks for the group for all those thoughts and ideas. No one else?
I can go next if you want, Chris. So we had a discussion about wearables and perhaps the value of Fitbits and others in terms of promoting behavioural change. Quite a discussion about the peer support groups and how it was rather on a one-to-one basis, having that peer group was actually potentially being beneficial. And like Gary, there's quite a discussion about what types of exercise you would do at home, discussion about gait training, use of poles and other aspects that might be improved. We all liked the co-create. We thought that was a really nice concept and look forward to see what comes out of it. And then I think, if you look at the cardiac rehab, I think, we moan about it not being available to patients with PAD, but the cardiac rehab program has been shown to improve survival and benefit. And we haven't actually looked at that in a proper trial. So if we actually could show that the added value of rehab in patients with PAD was to improve survival, then we might be able to get access and really focus how important it is to have a supervised exercise program for patients. That was it.
Thank you, Julie. That's really interesting thoughts. Yeah, brilliant.
So yeah, I just feedback from our group. We talked a lot about the importance of hearing from patients, people with the condition, about that for participants in projects and in developing interventions, but also more widely in terms of the research process, in terms of supervising the guidance and the groups that my brain's gone. What do you call them? Steering committees. That's it. Overseeing the guide and the guidance for the research, and also in the NHS itself, needing patient advocacy. And in terms of what's missing or what could do with more research, we talked about education a lot and how important that was, and also about advocacy and providing guidance for people who are diagnosed with the condition or newly diagnosed. There's a mass of information out there, and having ways of navigating that and finding out the bits that you need to know could be really beneficial. I think that covers it more or less.
Thank you very much. Really nice spread of ideas. Anyone else have anything that's not been mentioned yet that they were like to bring up there?
Could I say something, Chris?
Yeah, please, Kathy.
Just something that Julie said at the beginning about people, there being a common disease and not being picked up, and the burden for women, which obviously must be hugely expensive for the NHS. Now, it's common to go looking for cardiac involvement after a PAD diagnosis, but it's not common to look for a PAD diagnosis after cardiac involvement. And I definitely am a patient who would have benefited from that. But I could have done things differently in the 10 years between the CAD diagnosis and the PAD diagnosis. Now, if we could pick up that group in the future, then we could stop them ever getting to the point of having symptomatic PAD, because it would follow on from cardiac rehab. It's a simple test, as Julie said. It could easily be added on to those patients who are diagnosed with CAD, especially women who seem to have a particularly unrecognised need.
Thank you, Kathy. That's really interesting. That kind of links to that awareness that Julie was mentioning, and the kind of abundance of testing, or lack of abundance of testing and diagnosis. Great.
Could I ask a question to follow on from that, or maybe quantify what Kathy's saying?
Please, Kay, yeah.
Basically, women are cardioprotected until the menopause, and then with the lack of estrogen, obviously they become a higher risk. Sorry, I'm looking after some dogs in the backing. So basically, women over the age of 50 that are postmenopausal are at highest risk. I myself got to 54 and was diagnosed with PAD. Unfortunately, by the time I was diagnosed, I was CLI. And then became, I've had my procedure. It took 2 years in the NHS because of COVID, and also because you've got the old school vascular surgeons who want to cut you open and do a bypass. And then you've got the new school vascular surgeons and interventional radiologists and cardiologists who will do a procedure with wires, balloons and stents, etc. So there's a huge dichotomy of treatment out there. But as far as claudication is concerned, I always believe there should be a patient on the panel, because I don't think, with all due respect to researchers, professors, academics, etc., to try and explain the pain to anybody else is extremely difficult. And it's something that's not really addressed, because the level of pain, as I just said in the group breakout room, is something similar to childbirth, except it's happening in your legs or your buttocks or your thighs. And women do have, as Kathy said, a predisposition to this. And unfortunately, due to the fact that my procedure took 19 months, I also had to pay £1,000 for my own CT scan because of the COVID. The fact that I had to wait so long, I actually became a CAD patient because of the stress on my heart. I had a heart attack and I now have AF. But I'm a patient advocate for 12,000 patients, and I listen to their stories every single day. And I 100% believe that patients should be involved at all levels. And I endorse exactly what Kathy has said, if you don't mind me taking your time. Thank you.
Really appreciate that. Thank you very much, Kay, for sharing your story and your thoughts. That's really, really, really important, really interesting. Okay. I am aware of time, and I know we've just slipped past 3 p.m. So I would just like to pretty much finish up there, and thank you all very much for your time and your input. You know, your feedback, all these thoughts, we're recording all of this, and it's really important, really useful for everything that we're doing here. Yes, Julie, you want to come in there?
Chris, I was clapping, but I'll do it. I'll do it.
Oh, sorry, I thought there was a hand up. My fault. No, great. And yeah, so all that is left for me to say is that please keep in touch. Please, you know, I've got my details are there on the screen. We will include all of the study team's details when we send round the kind of a summary of the event. If you would like to get involved any more in any other way, then we'd be always willing and grateful for any input. So yeah, thank you very much for giving up your time and for coming along.